Welcome to OncoPharm. I'm your host, John Bazar. I'm a professor of pharmacy practice here at ETSU Bill Gatton College of Pharmacy, and we are sponsored by Kelly C. PharmD, an oncology education company for pharmacists. Today, we have a few topics to discuss. We need to discuss basically some recent FDA approvals that I haven't talked about. So the first approval that we're going to discuss is from February 19 of this year, and this is the approval of Acalabrutinib and venetoclax for CLL or SLL. Now this is not new data. This is from the Amplify study, which was published in February of 2025 in New England Journal of Medicine, probably presented at ASH maybe in 2024. We covered this on the podcast in some depth. Just as a refresher, this was three arms, Acalabrutinib and venetoclax, and that was 2 cycles of Acalabrutinib, and then you added the venetoclax with a ramp up with cycle 3 to continue basically a year and a month, or 14 total cycles with 28-day cycles of Acalabrutinib venetoclax. That's AV. There was AVO, which is Acalabrutinib venetoclax and obinutuzumab together, and then there was chemoimmunotherapy, which could either be FCR or BR. It was mostly BR. Now, if you remember at the time when this came out, the 36-month estimates for PFS were 76.5% with AV, good. With AVO, 83.1%, even better. And chemoimmunotherapy was 66.5%. This approval is for AVO. Back up. This approval is for AV, Acalaven, not the addition of obinutuzumab, despite numerically better PFS data, even though I'm pretty sure that wasn't compared statistically. They would have compared it to chemoimmunotherapy. Why? Well, the 36-month overall survival estimates with AV, 94.1%, pretty close to 100. That's what I like to see. AVO, 87.7%. It's like quite a bit lower than 94%, even though it had better PFS. And then chemoimmunotherapy was 85.9%, basically pretty close to AVO, despite AVO having better progression-free survival, right? So progression-free survival is an artificial endpoint. Usually it's looking at progression, not overall survival. And so we did not see the translation of overall survival. It sure looks like the adding obinutuzumab to Acalabrutinib and venetoclax had a detriment to overall survival. And if you look at the grade 3 or worse infection rates, it's 12.4% with AV, 10% with chemoimmunotherapy, 23.6%, almost 1 in 4 had a life or a serious infection with Acalaven obinutuzumab. So did not get the FDA approval, just Acalabrutinib venetoclax. Worth pointing out, it is a year and a month. It's 14 cycles. It's Acalabrutinib first at the standard dose, and then with the third cycle you add the venetoclax with the ramp up, and that is to help mitigate the risk, the delayed venetoclax and the ramp up to mitigate that risk of tumor lysis syndrome. Okay, so old data. The next old data to talk about that led to an FDA approval was the Breakwater study, which was published in May of last year in New England Journal of Medicine. And this is approval for Encorafenib in combination with cetuximab and modified FOLFOX in BRAF V600E mutated metastatic colorectal cancer in the first-line setting. The Breakwater was discussed, hotly anticipated. These were, newly diagnosed metastatic colorectal cancer patients with BRAF V600E mutation, and Encorafenib, with the RAF is a BRAF inhibitor. The main arms in this study are Encorafenib plus cetuximab plus FOLFOX. The Encorafenib dose is 300 milligrams daily. And standard cetuximab, standard FOLFOX, and then compared to FOLFOX with or FOLFIRI, so chemo with or without bevacizumab. It's always with or without bevacizumab, never definitely needing bevacizumab. Median PFS in the experimental arm, so EC, Encorafenib, cetuximab plus modified FOLFOX is 12.8 months, 7.1 months in our control arm with chemo plus or minus bev. Median OS was 30.3 months in the experimental arm, and half that, 15.1 months, in the control arm, has a ratio of 0.49. So pretty robust improvement in overall survival that we see. But it is Encorafenib oral, it is cetuximab, it is FOLFOX. a decently toxic regimen there, but you do get some robust overall survival benefit. None of that is necessarily new. Even that OS benefit was in the Breakwater publication. If you go through the Encorafenib PI, a couple things that stood out to me. And when the new PI is updated, you can see what is added new because there's like a little black bar on the left-hand side of the PI. And so there's an addition of some of the toxicity in Breakwater that isn't in the publication with regarding the dermatologic toxicity. So there's 5.6% of patients on Encorafenib and cetuximab and chemo who had a melanocytic nevus, which is in the secondary skin cancer section. I think a melanocytic nevus is a really fancy term for a mole that could become a melanoma, but is not yet a melanoma. So certainly attention should be paid to dermatologists examine these patients. And then we know that Encorafenib has a risk of QTC prolongation. It's usually less than 0.5% of a QTC corrected, or QTC above 500 milliseconds. But that was 4% in the FOLFOX and cetuximab and Encorafenib arm. So a little bit higher. Right? So we know oxaliplatin, for example, can have some QT prolongation. They're going to be getting more on danzatron, which at normal doses doesn't cause a ton of QTC prolongation that's clinically relevant, but there could have been some electrolyte abnormality. So worth paying attention to that. If you're very familiar with Encorafenib in the GI space, that QTC prolongation might be a little bit more pronounced in the community when it's used in the real world with cetuximab and with FOLFOX. Really, I would say be very vigilant about managing and monitoring your magnesium levels on cetuximab, since we know it can cause hypomagnesemia. Low mag can lead to QT prolongation. Low mag can lead to low K, low potassium, and that can also lead to QT prolongation. A lot of listeners to this pod tune in because they want, they're new to oncology, they're trying to get up to speed, or they want these quick weekly updates to help keep pace with the onslaught of new information in oncology. Well, if this sounds like you should check out the Oncology Insights newsletter. It's a free weekly email written by fellow Oncofarm Kelly Karlstrom, founder of Kelly C. PharmD and the ELO Collaborative Program. Each week she shares practical clinical pearls, ways to think through the concepts of oncology without just memorizing our favorite guidelines, and insights on staying motivated and growing in your practice. It's written by a pharmacist for pharmacists, and it's easy to read. Sign up in the link in the show notes. All right, the next update is Zongertinib, my favorite drug to say right now. This approval was February 26th. I had to do a double take. I was like, wasn't this this was just approved? I had to go back and look in the archives. I did a podcast about it in August of this year, or of 2025, because it was FDA approved then. I was like, what am I missing here? What I was missing is the approval in August of last year was in HER2 tyrosine kinase domain mutated non-small cell lung cancer after chemotherapy, second line setting. This approval is in the front line setting. So we have 70 patients that got it in the first line with ERBB2 mutated tyrosine kinase domain mutations, metastatic non-small cell lung cancer, 72 and 71 in each of these arms. First line setting, objective response rate overall 76%. Second line setting, 75%. Okay, so it doesn't seem to matter the efficacy of the drug, at least the activity of the drug. I shouldn't say efficacy because we're looking at response rate, not overall survival. But the activity of the drug seems to be the same, Zongertinib, if you're ERBB2 mutated before chemo or after chemo, okay? Platinum-based chemo. If it's given in the third line setting, so after chemo and a HER2 targeting antibody drug conjugate, that response rate was 44%, almost half of that 75-76%. So certainly that has an issue in folks who've already received, trastuzumab deruxtecan for ERBB2 mutated non-small cell lung cancer. Okay, nothing necessarily new there drug toxicity wise, and even this data in the first line setting was already available then. This is still an accelerated approval. We still don't have the full approval yet for Zongertinib. So, who knows? That still has to be confirmed for the drug to stay on the market. Now, the last update I have for you was expected. This is the approval of Teclistamab with Daratumumab, hyaluronidase, relapsed refractory multiple myeloma in the second line setting. This is based on the Majestic study, really, really big study. What is notable here, and what we talked about on the episode I did on this is old second line therapy. So these are folks who progressed on an RVD type regimen, so Revlimid or lenalidomide, bortezomib or Velcade, or dexamethasone. These are the patients in Majestic 3 who had all this benefit of Tec-Dara. There was a lot of toxicity early on we talked about. There were toxic deaths and neutropenia because they had to go back to the weight-based dosing versus the fixed dose they wanted to use of Teclistamab and to monitor immunoglobulin levels and supplement with IVIG. Once they did that, they got over those infection deaths. Big benefit of Tec-Dara in the second-line setting, but it was after RVD. It was after a triplet. Our current modern second-line therapies would be patients who have already had a CD38 monoclonal antibody like Daratumumab or Cetuximab. The patients in this study had not been exposed to Daratumumab before, okay? Or if they had, I think they had been off of it for at least 12 months, if I remember correctly. So if your practice is doing quads and then doing Dara maintenance, we don't know if Tec-Dara in the next line setting would work at all. And in fact, the data we have in other CD38 studies is we don't tend to see benefit if you progress on a CD38 monoclonal antibody to continue it in the next line setting. So the role in therapy immediately are going to be for those patients who have been on little antibody maintenance for a long duration of time and have not yet been exposed to Daratumumab. But certainly going to be a very popular regimen, good efficacy data. And so, we're thankful for that. Also, this approval converts the Teclistamab accelerated approval in the fourth line setting for folks, or maybe it's the fifth line setting. But Teclistamab was, but prior to this, was approved as an accelerated approval as monotherapy for relapsed refractory myeloma who received at least 4 lines of therapy, including a PI proteasome inhibitor, an IMiD like lenalidomide, and a CD38 monoclonal antibody. So this drug has an approval right now, or it's second line now, but before it was the fifth line. So jumped up a lot of lines of therapy from fourth or fifth line to second line. So Teclistamab looks like a good drug, a drug we'll use quite a bit, I think. That is what I have this week. This week. Hopefully not going to a wake this week. That's what I have for you this week. Thank you so much for listening. You can follow me on the dying social media X Twitter platform at Farnditnib and on other social media platforms at UncleFarmPod. And until I talk to you again, remember, doses matter.